Chapter 12, Disorders of Hemostasis, or Disorders of Blood Clotting. So we know that the purpose of hemostasis is to make sure that our blood stays within our blood vessels. And so we have processes inside the body that are called homeostasis that make sure that the blood clots into a semi-solid clot, and that we activate platelets to adhere and aggregate to make that plug in the body. This usually occurs in 3 stages. We're going to talk a lot about thrombopoietin, which is where we make the platelets that create our ability to clot. They're made in the liver and the kidney and in the bone marrow. And when we have diseases that affect these organs, they will also have an effect on our ability to clot. Megakaryocytes, which are formed in the bone marrow, also create platelets. So if we have issues in our bone marrow, we can have difficulty clotting. And last but not least, we have platelets, which are part of our blood makeup. These are released when needed. Most are stored within the spleen, and they have a very short lifespan of 8 to 9 days. So when platelets are released, there are chemicals that start the clotting by reacting with the blood proteins and help the platelets stick together. And this process, remember when we look at wound healing, is part of the wound healing process. It's normal. We want the platelets to stick to the vessel walls. We want the blood vessels to constrict. We want that bleeding to stop. There's a whole cast of characters in our plasma proteins. You do not have to memorize all the different plasma proteins, but know that the plasma proteins help with the coagulation factors to make this process happen, and that calcium is also involved. So again, when we have disorders in calcium, we may have disorders with clotting. So these things are beginning to link together for you in the bigger picture. When we have conditions in our body that lead to hypercoagulability, it means that we have a predisposition to have a thrombus or an occlusion because of this increased adhesiveness and aggregation that's happening within our veins and arteries. There's a chart on page 270, chart 12-1, that is a visualization of what I'm going to talk about here. When we have hypercoagulability, we have an increased number in our platelets. We have an increase in platelet aggregation, meaning sticking together. That platelet stickiness creates endothelial damage to that lining within our vessels, whether they be veins or arteries. When we create damage in our in that first line of defense, it starts the wound healing process or the inflammatory process, and it creates a big problem for us. There are multiple kinds of inherited mutations of blood clotting that one can inherit genetically. So we don't want you to have to memorize that at this point in time. You'll hit most of them when you hit pediatrics. But I want you to think of some of the predisposing factors that occur as a result of patient care that increase the risk of hypercoagulability in the body. So when I have prolonged bed rest, it creates a situation where hypercoagulability takes place. If I have blood dyscrasias that increase the viscosity of my blood, so too many red blood cells, polycythemia, I am at risk for blood clots. If I take medicines that create situations that increase coagulation, such as oral contraceptives, I can have an issue of where I have too many platelets and have increased risk for a blood clot. Or if I have disease processes that are going on in my body in other organs, such as the heart. So if I have a heart arrhythmia, such as atrial fibrillation, which creates a situation where my heart does not beat regularly, so it allows blood to pool, and we know that anytime we have blood pooling, that creates an opportunity for coagulation. So again, there are multiple ways that you can have hypercoagulability besides just the inherited ways. We need to know that thrombocytosis is diagnosed by taking the blood and just seeing what the blood count of thrombocytes is, and this would be anything that's greater than 1. We also have problems with decreased platelet levels, or thrombocytopenia. Means the same thing. I have either a decrease in production of my platelets, or an increase in the destruction of my platelets, or that my platelets are being used up so fast to formulate clots because of some massive trauma that I can't produce enough. But the bottom line is it negatively impacts platelet functioning. Inadequate platelet formation would occur when I had bone marrow deficiencies. Could be. So some causes of platelet disorders would be inadequate platelet formation, meaning I have some sort of bone marrow dysfunction that doesn't produce it enough for my body. Or I can have that excess, which would be thrombocytopenia, where I have too many platelets being destroyed in my body for some reason. Or I have abnormal platelet function, thrombocytopenia, for some reason. Something's causing that abnormal function. The bottom line is, in all three of these, the signs and symptoms are going to be the same. You're going to have increased bleeding from areas that may or may not normally bleed. So think of bruising under the skin, think of nosebleeds, think of GI bleeds, like from ulcers that are not massive, but are slow and continual. Think of bleeding from the rectum, bleeding from the oral mucosa, anywhere where we have contact where that epithelial tissue can be damaged, we can have bleeding. Thrombocytopenia is defined as less than 100,000 platelets, and spontaneous bleeding occurs at less than 20,000. And think of our skin and mucous membranes as the first place that we see that. Hemophilia is a specialized hereditary type of inadequate bleeding. That's all you need to know. The big one that we will see in the body, particularly in response to generalized trauma, so disseminated intravascular coagulation is a paradoxical disease where there is widespread coagulation and bleeding at the same time. This is not a primary disease at all. It is usually a result of a complication of another disease, where there's massive activation of the coagulation sequence or formation of fibrin thrombi. It results in tissue ischemia and death related to the tiny microclots that are in the microvascular vasculature, and it creates a situation where there is more platelet destruction leading to more hemorrhage. So listed in this diagram are some of the intrinsic and extrinsic types of injury that occur that may lead to DIC. Massive trauma and pregnancy and cancer and sepsis being the most important ones. Early signs and symptoms of this disease, it's important, very important to catch this early on, because by the time you get down to hemolytic anemia and tissue ischemia and just all-out bleeding, we can have a very much difficulty in stopping the person from dying. So we want to know what this looks like early on, and that would be signs of petechiae and purpura, simple oozing from epithelial skin, or open or wounds. By the time we get to hemorrhage and hemolytic anemia, it's pretty much too late. We diagnose this by looking at platelets. The platelet count will be less than 1,000. The fibrinogen levels will also be decreased, and the prothrombin time will be prolonged, and the partial prothrombin time will be prolonged. Generally, because of the microclotting that occurs with this disease, it microclots in the kidneys, and you'll see a reduced urine output, less than 30 milliliters per hour, and you'll see some effects on the BUN and creatinine by elevation because of the poor kidney functioning. How we fix this or treat this is to replace the clotting components. So we transfuse fresh frozen plasma or platelets or specific clotting factors if we know that it's due to a lack of a clotting factor. But what you need to know is this is a emergency situation that happens kind of insidiously, because if you look at here I am having a baby, I'm not anticipating that something like this can happen, yet having a baby is, postpartum is one of the places where we worry about postpartum hemorrhage and DIC extensively, and so we need to be diligent in looking for the signs.